Boa tarde a todos. É um prazer enorme poder estar iniciando esse evento em nome do professor João Luiz, que é o nosso coordenador da pós-graduação do Ciência Animal. Ele teve um problema técnico com o computador, mas ele está nos acompanhando pelo YouTube, tá? Pessoal, é um prazer para mim poder estar aqui apresentando. Então, inicialmente eu vou falar em português e daqui a pouco a gente vira a chavinha, que o Dr. Hall já está na sala aqui com a gente, tá? Bom, então, hoje e amanhã nós teremos as palestras, né, com o pessoal da University of Mississippi Medical Center, em Jackson, dos Estados Unidos, e hoje nós iremos iniciar com o Dr. Hall. Muito obrigado a presença de todos. No final da apresentação do Dr. Hall, vocês podem ir colocando as perguntas no chat, que delas vão ser projetadas aqui. As perguntas podem ser em inglês ou em português, e aí eu vou versando para o Dr. Hall na medida do possível e, lógico, né, do tempo dele também. Então, muito obrigado pela presença de todos. A partir de agora, nós vamos adicionar o John Hall na tela. Eu vou começar a falar em inglês. So, hello, Dr. Hall.
Hello.
Can you hear me?
Yes, I can.
Okay, so thank you so much. I will do your presentation for our public. So, Dr. John Hall is affiliated with the University of Mississippi Medical Center since 1974. Is currently the Arthur C. Guyton Professor of Physiology and Chair of the Department of Physiology and Biophysics in UMMC since 1989. Dr. Hall is the director of the Mississippi Center for Obesity Research. Dr. Hall's research has focused on multiple aspects of cardiovascular, renal, and endocrine physiology. And today he will talk to us about general topics on obesity, hypertension, and kidney dysfunction. Dr. Hall, welcome to our webinar. Thank you so much for your time with us and for accepting our invitation. Me, Londrina State University, and we have also students and professors for other universities that are here and really excited for this moment. Thank you so much for this, and I will pass you the word. Thank you.
Muito obrigado, Fabio, and boa tarde to the audience. That's the limit of my Portuguese, so I'm going to go ahead and speak in English. I apologize for that, but welcome to my office. Okay. I apologize that I'm not able to be there in person. So I'm going to share my screen now, try to see if I can share it.
Okay.
And let's see. So. Are you able to see the screen now?
Yes, we are.
Okay, well, again, thank you very much. And today I'm going to spend a little bit of time talking about obesity, kidney dysfunction, and hypertension. And I understand that tomorrow, Dr. Alexander De Silva and Gisara De Carmo will also talk about some of the work that's ongoing in our laboratory. And I've just listed a few of the areas that we've been working on, and I'm glad to say that Fabio has been very instrumental in some of the work that we've been doing, particularly related to myocardial infarction, cardiac ischemia, and so forth. But today I'm going to focus on one of the topics that we're working on, and that's obesity, how it leads to kidney dysfunction and hypertension. I think everyone is probably aware of the fact that obesity is one of the global health challenges now. In fact, the World Health Organization estimates that there are over 2 billion people in the world who are either obese or overweight. So it's not only a global health concern, but it's also an economic concern. And in the United States, we've seen a tremendous increase in the prevalence of obesity over the past 20 or 30 years. In fact, also a parallel increase in diabetes. And it's estimated now that about 70% of US adults are overweight and about 40% are obese. And the same trends have been noted worldwide. We have more obesity than many countries, but worldwide, there has been a tremendous increase in the prevalence of obesity in children as well. And so you can see here that Brazil, as an example, has also increasing levels of obesity in children, which means we're going to have even more obesity in the future, because about 80% of obese children become obese adults. Even our pets are overweight. In the US, it's estimated that over half of dogs and cats that go to clinic are overweight or obese, and this has led to health problems in obese pets as well as obese humans. And associated with obesity, of course, is a cascade of cardiovascular and metabolic disorders, which has often been referred to as the metabolic syndrome. However, it's clear that obesity is the primary driver for all of these disorders, including hypertension, the main area that I'm going to focus on today. And we know that hypertension, of course, is the most important risk factor for cardiovascular disease, heart attack, stroke, and also a major risk factor for chronic kidney disease. Now, the importance of obesity as a cause of hypertension has been well established, first from animal studies, which I'll share some of that with you today, from clinical studies showing that weight loss lowers blood pressure in most hypertensive patients, and from a large number of population studies showing that excess weight gain is perhaps the best predictor we have for subsequent development of hypertension. In fact, most hypertensive patients are overweight, and the results from the Framingham Heart Study and other studies suggest that at least 65 to 75% of the risk for primary hypertension is due to excess weight gain. Now, one of the questions that I often get is, if obesity is so important in causing hypertension, why is it that some obese people are not hypertensive? I think we can address this issue by considering the fact, first of all, that blood pressure has a frequency distribution. And what obesity does is to shift that frequency distribution toward higher blood pressures. And so even in those individuals who fall within the normotensive range, if they lose weight, their blood pressure falls to a lower level, indicating the importance of weight gain or excess weight gain in raising the blood pressure. The other thing to keep in mind is that the longer you have obesity, the more severe the hypertension and the more severe the target organ injury. And then the third thing to keep in mind is that it's not just the total amount of fat that's important, but it's the location of the fat. We know that visceral fat, pararenal fat, and kidney sinus fat are much better predictors of hypertension compared to subcutaneous fat or body mass index. So although the importance of obesity in causing hypertension is well established, the mechanisms are not as well understood. And there's certainly been many mechanisms that have been proposed to explain obesity hypertension. I've shown just a few of these that have been proposed. And I think for many of these, we have to say that we do not know if there is a clear cause and effect relationship. So in many cases, there is simply an association rather than a cause and effect relationship, which has been established. So in order to try to understand the causes of obesity-induced hypertension, we've used a large number of animal models as well as human studies. And what we've found from these studies is that animals fed a high-fat diet from 6 to 52 weeks seem to mimic fairly closely what we see in obese humans, with increases in blood pressure, elevated heart rate, increased cardiac output, activation of the sympathetic nervous system and the renin angiotensin aldosterone system, increased sodium reabsorption by the kidney and volume expansion, hyperfiltration in the kidney or an increase in GFR, which acts as a compensation for the increase in sodium reabsorption, and then a host of metabolic abnormalities, including insulin resistance, dyslipidemia, and other metabolic disturbances. And from these studies, we've suggested that there are at least 3 mechanisms that contribute to the initiation of obesity-induced hypertension. And I want to emphasize initiation, because once the hypertension is established, once it's occurring over a long period of time, we have a number of secondary changes that result from target organ injury. But the first of these changes is physical compression of the kidneys. If we look at the kidneys of obese dogs, obese rabbits, and obese humans, you see that there is fat that completely encapsulates the kidney. In fact, it adheres to the kidney, it penetrates into the renal sinuses, and we've suggested that this acts as a compressive force on the kidney. Now, in rodents, in mice and rats, we do not see this adherence of fat to the kidney. In fact, any of you have done studies in obese rodents, you know that the kidney just seems to be swimming in the fat. It doesn't really, the fat does not adhere to the kidneys. But in humans, we see the same thing that we see in dogs and rabbits. We see that the fat adheres to the kidney, it adheres to the capsule, and it penetrates into the renal sinuses. And so we've suggested that this fat adhering to the kidney and compressing the kidney could lead to an increase in blood pressure, in part by raising sodium reabsorption by stimulating the renin-angiotensin aldosterone system. And one part of the kidney that's especially susceptible to this compression is the thin loop of Henle. This segment, of course, has a very thin wall. It's easily compressed, and fat, we think, compresses the loop of Henle, reducing the flow rate through the loop of Henle, increasing the fractional reabsorption of sodium, reducing the sodium chloride delivery to the macula densa, which then could explain why there's an increase in GFR and the stimulation of renin secretion through this macula densa feedback mechanism. Now, support for this idea comes from our observation in dogs, and as well as in rabbits, that there is a marked increase in the kidney interstitial fluid hydrostatic pressure, almost double what we see in normal individuals or normal dogs. In humans, there's also a good relationship between sagittal abdominal diameter, which is a pretty good marker for visceral obesity, and intra-abdominal pressure. And you can see the pressures here rise pretty high in these people who are severely obese in terms of visceral obesity. And in fact, results from the Framingham heart study suggest that fatty kidney, and particularly renal sinus fat, is highly associated with hypertension as well as chronic kidney disease. And there are several studies now showing this association. So we think that physical compression of the kidney could play an important role in the development of obesity-induced hypertension. The second mechanism appears to be mild activation of the renin-angiotensin-aldosterone system. And I emphasize mild because if you look at the levels of renin and aldosterone, you can see that they're only slightly elevated. In fact, sometimes they're not even significantly elevated. On the other hand, if we block the renin-angiotensin system, in this case in obese dogs, with an ACE inhibitor, you can see that there is a substantial fall in blood pressure. And not shown here, there's also a significant reduction in plasma aldosterone level. But despite the decrease in aldosterone levels, when we add the mineralocorticoid antagonist eplerenone, you can see a further reduction in blood pressure. So there appears to be an additive effect of mineralocorticoid blockade and angiotensin converting enzyme inhibition. And the same result has been seen in humans that are obese. Treatment-resistant obese hypertensive humans that are already on ACE inhibitors or an angiotensin receptor blocker and at least 2 other medications. You can see that giving the mineralocorticoid receptor antagonist spironolactone has a very substantial effect on blood pressure, both systolic and diastolic blood pressure. So what these studies show is that mineralocorticoid receptor activation as well as angiotensin 2 are contributing to the development and the maintenance of obesity-induced hypertension. But one of the questions that arose from these studies is why is mineralocorticoid receptor blockade so effective in treating obesity hypertension if the aldosterone levels are not elevated in some cases or even actually slightly reduced? So we considered the possibility that perhaps there may be some other factor activating the mineralocorticoid receptor, particularly glucocorticoids. Now, normally the primary glucocorticoid that circulates in the blood is cortisol. It has a concentration which is much higher than aldosterone, and cortisol has a high affinity for the mineralocorticoid receptor. Under normal conditions, however, cortisol does not act on the mineralocorticoid receptor in the kidney because of this enzyme 11-beta-HSD2, which converts cortisol to inactive cortisone, which does not bind avidly to the mineralocorticoid receptor. When there is a deficiency of 11-beta-HSD2, such as we see with apparent mineralocorticoid excess syndrome due to licorice ingestion or to genetic deficiency, then cortisol is able to bind to the mineralocorticoid receptor, leading to hypertension, which looks like aldosterone hypertension, except the aldosterone levels are not elevated. It's cortisol that's activating the mineralocorticoid receptor. So we wondered whether or not there might in fact be a deficiency of 11-beta-HSD2, which could partially explain why the mineralocorticoid receptor is being activated. And to make a long story short, we did find that there's about a 65% or 70% reduction in the 11-beta-HSD2 protein of the kidneys of obese dogs. So this at least would suggest that perhaps a reduction of 11-beta-HSD2 may be a factor in allowing glucocorticoids to activate the mineralocorticoid receptor in addition to aldosterone. But regardless of the mechanisms, it's clear that both mineralocorticoid receptor blockade and angiotensin blockade are both effective in reducing blood pressure and preventing sodium retention, and also preventing target organ injury in obesity-induced hypertension. These drugs have not been widely used in treating obesity hypertension. They are used now more frequently in treating resistant hypertension, but I think that this type of study suggests that we perhaps should be using the mineralocorticoid receptor antagonist more frequently. So the third mechanism that appears to be important is mild activation of the sympathetic nervous system. Several studies, including studies from our own lab, have shown that sympathetic activity is elevated. There appears to be a mild activation of the sympathetic system. It's not sufficient to cause vasoconstriction. It is selective in the sense that not all organs have increased sympathetic activity, but one of the organs that does have increased sympathetic activity is the kidneys. And we've shown that if we block the sympathetic nervous system, in this case, using a combination of prazosin and propranolol, alpha-beta blockade, that we can block about 60% of the hypertension that occurs in dogs which become obese by feeding a high-fat diet. We've seen the same sort of result in human studies where we block alpha-beta receptors in obese hypertensive humans, and you can see that we have a much greater reduction in blood pressure compared to lean hypertensive humans. So it appears that sympathetic activation is a key factor in maintaining and in the development of obesity-induced hypertension. This appears to be mediated in large part by the renal nerves. If we denervate the kidneys, for example, in this case, using a radiofrequency ablation technique, in which we put a catheter up into the renal artery and then ablate the nerves that run along the adventitia, and you can see that this leads to a reduction in blood pressure, even though in this case we only reduced the renal innervation by about 42%. The same result has been seen in human studies now. Clinical trials have been conducted at 3 major sham-controlled randomized trials showing similar results that we saw in obese dogs. Now, one of the things that that has really slowed down this area a little bit is the fact that denervation is difficult using the catheter-based techniques. Using these techniques, typically, we can only get about 50% denervation, partly because some of the renal nerves do not run along the adventitia. They run in different angles toward the kidney. So with the radiofrequency technique, typically we can only get about 50% denervation. And we've shown in this study that, or this comparison here that if we surgically denervate, we get about twice as much reduction in blood pressure, and we get almost complete denervation, as evidenced by a 96% reduction in the renal norepinephrine content. So it's clear that the renal nerves are playing a key role in linking obesity with increased blood pressure, not only by directly increasing sodium reabsorption, but also by stimulation of renin release. There is an increase in heart rate in obesity. We think that this is largely due to withdrawal of parasympathetic tone, at least in dogs and humans. So the big question that we've been focused on recently is, what are the mechanisms that link obesity with sympathetic activation? We've seen that there is baroreceptor dysfunction in obesity. We've also seen that there is some chemoreceptor activation, particularly in patients with obstructive sleep apnea. But one of the interesting and recent mechanisms is the potential role of leptin, which is, of course, released by fat cells. Leptin is released by fat cells in proportion to the degree of adiposity, and it's known to act on the hypothalamus not only to reduce the food intake, but also to stimulate sympathetic activity and to increase energy expenditure. And we showed a number of years ago that this increase in sympathetic activity also contributes to an increase in blood pressure. If we, for example, infuse leptin at a rate that mimics the blood levels that we see in severe obesity, if we infuse leptin into lean animals, we get an increase in blood pressure. We've also seen that in animals which are deficient in leptin, such as the OBOB mouse or in leptin deficient humans, these individuals and these mice become extremely obese. They have essentially all of the characteristics of the metabolic syndrome: hyperinsulinemia, dyslipidemia, insulin resistance, very obese, but they do not have an increase in blood pressure. In fact, sympathetic activity and blood pressure tend to be lower than normal, suggesting that a functional leptin system is important in linking obesity with sympathetic activation and hypertension. Now, one of the key pathways by which leptin appears to stimulate sympathetic activity is by activating the pro-opio melanocortin neurons, or the POMC neurons, which are located in the arcuate nucleus of the hypothalamus, but also in the brainstem. These neurons send projections to second-order neurons in the paraventricular nucleus, for example, where they release alpha-MSH, which is an agonist for the melanocortin-4 receptor. These second-order neurons then send projections to the brainstem, where they are thought to regulate food intake as well as sympathetic activity. And we demonstrated in a series of studies that if we selectively delete the leptin receptor only on the POMC neurons genetically, that this can essentially abolish the increase in blood pressure. And we did this by using Krelok's recombinase technology to selectively delete the leptin receptors only on the POMC neurons. So these mice, for example, have leptin receptors everywhere in the body except for the POMC neurons. And these studies were done by Gisaro de Carmo, and you can see that in these mice with absence of leptin receptors only on the POMC neurons, that there is no increase in blood pressure when we infuse leptin over a period of 7 days. So the POMC neurons appear to be extremely important. We also looked at the effect of blocking selectively the melanocortin-4 receptors, either using genetic techniques or pharmacologic techniques, in a series of publications. And we found, for example, that mice which are deficient in the melanocortin-4 receptor and humans which are deficient in the melanocortin-4 receptor become extremely obese. Again, they have all the characteristics of the metabolic syndrome, except they do not have elevated blood pressure and they do not have an increase in sympathetic activity. So these data suggest that leptin activates the POMC neurons and then subsequently activates the melanocortin-4 receptors. These actions contribute to the increase in sympathetic activity. There's also baroreceptor dysfunction, which fails to buffer the increase in blood pressure. And there's evidence for chemoreceptor activation in obesity as well, particularly in patients with obstructive sleep apnea. The increase in sympathetic activity directly increases sodium reabsorption, but also activates and contributes to activation of the renin, angiotensin, aldosterone system. In addition, we suggested that a deficiency of 11-beta-HSD2 may also be a factor in activating the mineralocorticoid receptor. And then the third effect is the physical compression of the kidneys by the visceral fat and renal sinus fat. All of these together increase sodium reabsorption, contributing to the elevation in blood pressure. And the increase in sodium reabsorption then leads to a compensatory vasodilation of the kidney, hyperfiltration, which along with the rise in blood pressure and along with the various metabolic abnormalities contributes to renal injury. When we have renal injury, of course, this leads to further elevations in blood pressure over time and further renal injury, and in some cases, a slowly developing positive feedback, which can, in some patients, lead to chronic kidney disease or even end-stage kidney disease. The importance of obesity in causing chronic kidney disease is obvious if we think about the two main drivers of chronic kidney disease, which are hypertension and diabetes, both of which are closely associated with obesity. But in addition, there's clear evidence also that obesity is an independent risk factor for end-stage kidney disease. This is one study of over 300,000 subjects showing that there is a clear association between the degree of obesity and the increasing risk for end-stage kidney disease, even after adjustment for diabetes. So we think that obesity is a major driver of chronic kidney disease as well as hypertension. Now, the current therapeutic approach to treating obesity, hypertension, of course, is to treat the associated risk factors, particularly hypertension. We do have good drugs for treating hypertension. We don't have good control rates in most countries. And I think part of that's due to the fact that we don't use effectively the various physiological tools that we have, particularly the mineralocorticoid receptor antagonists. But it's also important to treat the other associated risk factors, particularly all these metabolic changes. And of course, the heart failure, the kidney injury, we know that these are difficult to treat. So this approach, treating the risk factors, of course, requires many different drugs. In some patients, 3 or 4 more drugs are needed to treat the hypertension. Several other drugs are needed to treat the metabolic factors. In many cases, this approach is not effective. It's certainly very expensive because of the use of these multiple drugs. A more appropriate approach might be to treat the underlying cause, which is obesity, by reducing caloric intake, increasing physical activity. Unfortunately, we're not doing a very good job of increasing physical activity, despite the proliferation of health clubs, at least in the US. 75% of US adults still get insufficient physical activity to maintain good health. And we also know that diet and exercise, even though you may get good results in the short term, that in most patients that follow a lifestyle modification, there's a high recidivism rate with weight regain over a 1 year and certainly over a 5-year period. So diet and exercise are still recommended, but there's a high recidivism rate. And we know some of the reasons for this. We know that when you restrict food intake, this increases hunger, it reduces metabolic rate through various hormonal mechanisms. And this obviously has survival advantage when food is scarce, because it makes you seek food, it makes you reduce your metabolic rate and energy expenditure. But at the same time, in our current environment of abundant food and sedentary lifestyle, it also leads to the failure of dietary therapy. So lifestyle modification can work in some individuals. We know that even a 5 to 10% weight loss can be effective in improving blood pressure control, improving the various metabolic factors. But we also know that there's a high recidivism rate, and it's certainly not a good solution for many people. Pharmacotherapy is recommended as an adjunct to lifestyle modification. Starting in 2012, there were a number of drugs that were developed. There were 5 drugs over this time period that were developed, including orlistat, which is an older drug. But these drugs, despite the fact that they do have some effect to reduce body weight and reduce adiposity, are not widely prescribed for a number of reasons. First, they're expensive. Second, they're only partially effective, typically producing only a 5 to at most 10% weight loss. And then third, many of these drugs have important side effects. In fact, lorcaserin, for example, was removed from by the FDA in the United States, mainly because of increased cancer risk. And these other drugs also have some important side effects. But still, they are recommended to be used as an adjunct to lifestyle modification in those patients who've been unsuccessful with diet and lifestyle modification. The third potential way to treat obesity, of course, is surgery. Keep in mind that surgery is currently recommended, at least in the US, only for those individuals that have a BMI greater than 35 to 40 or that have comorbidities that associate with obesity. There are a number of procedures that are used. The 2 that are most effective are the Roux-en-Y and vertical sleeve gastrectomy. These procedures are rapidly increasing, at least in the US. You can see that the tremendous increase, in fact, in more recent years, even further increases in bariatric surgery. And the reason that they're so popular now is that they work. About 70% remission rate of type 2 diabetes and about a 50% remission rate of hypertension with vertical sleeve gastrectomy or the Roux-en-Y surgery. And one of the best studies that was done to show the effect on blood pressure was the Gateway study, which was done by Dr. Carlos Chivan from Brazil, who showed a 51% remission of hypertension. That is, no drugs were required in 51% of the patients who were treated with bariatric surgery. There was 100% remission of resistant hypertension. And by resistant hypertension, we mean that at least 3 drugs were required to control the blood pressure. After bariatric surgery, none of the patients required 3 or more drugs to control the blood pressure. In fact, on the average, the patients required less than 1 drug to control the blood pressure at a level which averaged 123/78. So pretty good control rates with bariatric surgery. Now, one of the things that's been observed is that bariatric surgery causes a rapid remission of both diabetes and hypertension, even before there's substantial weight loss. And the mechanisms for this are not clearly understood. A number of mechanisms have been proposed, but one of the things that's been learned recently is that just a simple, rapid reduction in caloric intake can, for reasons that we don't fully understand, can reduce sympathetic activity and blood pressure just in a few days. So if you go on a really marked reduction in caloric intake for a few days, typically blood pressure is reduced. The more chronic effects of bariatric surgery appear to be related to the things that I've talked about: low sympathetic activity, reduction in renin-angiotensin aldosterone system activation, and reduction in visceral fat and kidney compression. In addition, it's also been shown in recent studies that bariatric surgery prevents the progressive loss of kidney function, and also may be very important treatment for patients with heart failure. In the past, people have been reluctant to do bariatric surgery in heart failure patients, but now it appears that it is an effective way to slow down some of the progression in heart failure as well. And this is one study showing the reduction in major adverse cardiovascular events over an 8-year period in patients who were administered bariatric surgery compared to non-surgical controls. So bariatric surgery is an important tool. It certainly is important in many patients, But keep in mind that bariatric surgery is not being done in most obese patients. In fact, only a small number of patients are receiving bariatric surgery compared to the large number who actually are obese and have metabolic and cardiovascular abnormalities. So this brings us to the last point I want to talk about, and that is, should we focus more on prevention? I think that when we consider the fact that obesity seems to be transmitted to future generations through fetal and epigenetic programming, this raises the question of whether we really need to focus more on prevention. There is a large amount of evidence, both from clinical studies and studies in animals, showing that maternal obesity can program the offspring to obesity, insulin resistance, and a host of cardiometabolic disorders. And this appears to occur through two effects. Number one, in utero fetal programming, and secondly, perhaps through transgenerational gamete programming. And what I mean by that is that the gametes, the sperm cells from the obese father, as well as the egg from the obese mother, appear to be programmed through epigenetic means to be transmitted to future generations. Now, the best evidence for this comes from studies in rodents, showing that if you take sperm from an obese father or eggs from an obese mother, and you fertilize the egg in vitro, and then you implant the fertilized egg into a lean surrogate mother, that the offspring become obese. And this is true whether you use the sperm of the obese father or the egg of the obese mother or the combination. And it's also been shown that if you look at the sperm, for example, of obese people, obese rodents, and obese flies that are fed sugar water, that there's a host of epigenetic changes that are taking place in the gametes, including chromatin conformational changes, changes in DNA methylation, and changes in microRNA. Now, whether these can be transmitted to future generations in humans is not clear, but in rodents, for example, these changes are transmitted for at least 2 generations. So this, I think, points out the importance of prevention. It's especially important when we consider the fact that obesity is I think, the major health problem that we're going to face in the future, besides COVID, of course, which is our major health problem right now. But in terms of our chronic diseases and hypertension, obesity is a major driver, accounting for 65 to 75% of the risk for primary hypertension, and probably at least 74, 75% of the risk for chronic kidney disease. Obesity in children is rapidly increasing, and we know that about 80% of children who are obese become obese adults. And we know that the longer that you are obese, the greater the risk for chronic kidney disease and cardiovascular disease. The frightening part of all of this is the possibility that there may be programming of obesity through not only in utero programming, but epigenetic programming of the gametes. And the fact that in rodents this can be transmitted for 2 generations is really an interesting and exciting area for research, but also an important reason why we need to focus more on prevention. So it's not just your gene or your genetic code that's important, but the way that obesity affects the expression of the genetic code through the gametes and through somatic epigenetic changes. So there are still many important questions. This makes an exciting area for research. I think it's an important area for research because of the high prevalence of obesity, but also because of the fact that obesity is rapidly becoming our most important health problem, secondary to COVID right now. I want to close by thanking many members of our department who have contributed to the work. This just is a picture of our physiology department. I want to especially acknowledge the people in our laboratory. You're going to hear from Dr. DeCarmo and Dr. De Silva about the work that we've been doing, and I also want to express my thanks to many other people. And I also want to acknowledge the fact that we've had many Brazilians in our laboratory over the years. They've really contributed importantly to our work. The first Brazilian to visit our laboratory was Dr. Elio Salgado. Many of you know Elio. He is a professor at the University of Sao Paulo and Ribeirão Preto. Dr. Salgado was the first to visit, at least in my laboratory. Subsequently, we've had many postdoctoral fellows, including Fabio, who spent some time with us in 2018, and then a large number of students, particularly medical students. I've just shown a few of them here. I've noticed that we have a lot of pretty girls from Brazil that have visited us, so we're really grateful for that. And Fabio, we are really, really grateful for Fabio. He visited us in 2018, and he had a lot of fun, I think. And this just shows some of the pictures of Fabio. He tells me that this is the first time he actually saw snow. This is very unusual for Mississippi, so for those of you who are thinking about visiting, we don't have snow very often. He attended football game, which is a different kind of football than you have in Brazil. He experienced the Mardi Gras. You can see him here. He involved in team sports and ice skating also, which you probably don't have that much of in Brazil as well. But Fabio did do a lot of work while he was here. In fact, he completed some really nice work on myocardial infarction and protection against myocardial infarction, and received a couple of important awards for his research. So Fabio, thank you for the work that you've accomplished while you were here. We hope that you'll come back and see us again. And finally, I just want to invite those of you who are on the line, if you had a chance to visit Mississippi, we would really be grateful to have you come visit us. And if you are interested in the research that we're doing, certainly be glad to have you come visit us once the COVID situation has passed over. So again, muito obrigado. We really appreciate the opportunity to talk to you today, and I'll be happy, if time permits, to answer any questions that you might have. Thank you very much.
Hey, Dr. Hall, I am speechless right now. Thank you so much. It was a very, very good time when I was in my postdoc with you and looking for that pictures. Okay.
I have some more pictures. I have more pictures, actually.
Okay, that was good ones, good ones. Thank you so much. Dr. Hall, thank you for the excellent talk. It was really brilliant. I really love it. So we have here some questions, if you have some time, that I would like to do for you, right?
Yes,
Okay, so good. The first question comes from Giovanna. Adiponectin concentration is known to be inversely proportional to the insulin resistance. Supplementing adiponectin in diabetic or obese patients could be a therapeutic target?
I think that's a good question. I believe that adiponectin does have an important role in insulin resistance. We have not seen adiponectin to play such an important role in blood pressure. Now, there are some studies that show that adiponectin deficiency, which does happen in visceral obesity as the fat cell expands, there is a reduction in adiponectin secretion. There's some evidence showing that adiponectin deficiency can cause salt sensitivity of blood pressure. But most of the studies don't show a major effect of adiponectin on blood pressure directly. But there is an effect through insulin resistance. And in the long term, of course, insulin resistance, hyperglycemia that occurs could cause kidney injury, which in turn might play a role in the long-term effects, not so much in the short-term or initiation of the hypertension, but it's a very good question.
Perfect, thank you. So the second question that we have here is from Patrick. This is the one that I like it. Diastolic function may be impaired with obesity. Is this dysfunction due only to an increase in preload, or could have other mechanisms linked with diastolic dysfunction in obese patients?
Yeah, I think, so the question relates to preload. I think afterload probably is more important in terms of diastolic dysfunction. It's very difficult to find patients. The heart failure with preserved ejection fraction is the classic example of obesity-induced hypertension and diastolic dysfunction in the absence of a heart attack. So, the question, we are actually studying that right now, as you know, Fabio. But I asked the clinicians, do you see patients that don't have hypertension that have diastolic dysfunction? It's rare. So hypertension certainly plays a key role, and that's through afterload effects. The preload effect, of course, causes eccentric hypertrophy, enlargement of the ventricle, which probably is not the major driver for diastolic dysfunction, although certainly could contribute to arrhythmias and other things that are associated with obesity. But yes, the enlargement of the ventricles and atrium could be obviously have bad effects, but I think the more important effect in terms of diastolic dysfunction is the afterload effect of the hypertension.
Perfect. Thank you. Third question from Ana Paula. Among the various possibilities that may be linked to the relationship between obesity and the development of chronic kidney disease, inflammation, lipotoxicity, is there any suspicion of the main cause? I mean, could have one that is main important?
Yeah, I think that, there are two things that work together, and I think in a synergistic way. Of course, hypertension and diabetes both work together. And the thing about obesity that makes it especially important is one of the things I didn't talk too much about, but that the kidney is actually vasodilated to start with. So the afferent arterioles become vasodilated. That allows greater transmission of the hypertension to the glomerular capillaries. So in diabetes, there's also the same effect, greater transmission of the hypertension to the capillaries. But it looks like from our studies and from studies in the literature that there's a synergy between the diabetes and the hypertension that really act together to drive much of what we consider chronic kidney disease. Now, of course, inflammation also accompanies all of that. And once the injury takes place, then you get inflammation. Inflammation is a way, of course, of trying to combat the initial injury, to clean up the debris that occurs from the injury, but it can also exacerbate the injury once it gets out of control. So yes, there is a complex cascade of events that takes place, but I think the two initiating and driving factors are the hypertension, the vasodilation of the afferent arteriole, and the diabetes and lipid abnormalities that take place.
Very good. Thank you so much. Next question, if you are fine, keep talking with us.
Yeah, that's fine.
Okay. We have some
blocked
more.
out my time, so I'm
Okay.
I'm good.
Good, thank you. So it's from José Victor. Obesity has been pointed out as an important cause of chronic kidney disease. On the other hand, is there notably renal alterations and or severe damage to those patients who lose weight quickly through miraculous diets, for example?
Yeah, I think, the best example of people that lose weight quickly are the people that undergo bariatric surgery. Mm-hmm. And one of the things that's been shown in patients that undergo bariatric surgery is that it does slow progression of chronic kidney disease in a very pronounced way. Unfortunately, most people aren't able to lose a lot of weight just by diet and exercise, but those people that do lose weight by diet and exercise, it does slow the progression of chronic kidney disease. And again, it depends on what stage you're in. I think one of the things that we need to do more of is to focus on the early stages of injury. Initially, there's a hyperfiltration, and if untreated, that hyperfiltration turns into a normal GFR and then a reduction in GFR. So if you're obese and you have a normal GFR, that means you've already got some kidney injury because it should be elevated as a result of the hyperfiltration. So I think we really need to focus on treatment early on. The standard therapies now are ACE inhibitors or angiotensin receptor blockers. I think mineralocorticoid receptor antagonists are very, very important. Dr. Rogério de Paula, who is from Brazil, did a study with us quite a few years ago showing that mineralocorticoid receptor antagonism really prevents the hyperfiltration that we see with obesity in dogs. So there are a number of ways that we can treat, but you're right, the best way to treat is to lose weight.
Very good. Thank you. Next one from Marlene. Considering that processed foods have a lot of influence on people's health, when will the food industry be questioned about the ills of obesity in the population?
Yeah, that's a great question. I think people are doing that right now. One of the things that I've been involved in over the years is the issue of sodium. Sodium is a toxic substance if it's eaten in large amounts. But I think your point is that there are other things that are in foods that may not be very healthy for us. It's being questioned more perhaps in the UK, the United Kingdom, and in Britain than in the US. We have many lobbyists who fight against questioning the food industry. So it's a challenge. It's always a challenge to get the food industry to change their behavior. They do what makes money.
Yeah, for sure. So now we have here last question is from Mariana Podleskis. Mariana is an undergraduate student here from Veterinary College.
Okay.
So as we could see in your speech, so she started her question like this. Here in Brazil, but as we saw in your slides in USA as well, we have a lot of obese pets, dogs and cats. And in most of cases, the owners are also obese.
Yeah.
So do you think that it is interesting research that demonstrate this fact like numerically in order to prove that influence of human behavior in obesity?
I think that's a really, really good question. In fact, my slide that I showed, the obese dog was sitting on the lap of an obese owner. And I think you're absolutely right. I don't think that there is a study that I'm aware of that shows that, but I think that's an interesting point. It would be a really nice study. So congratulations on thinking about that. I think we all feel that way, but I personally don't know of a study that actually shows that in a quantitative way.
Yes, we have here our veterinary teaching hospital with a lot of cases, a lot of pets, and a lot of owners. So yes,
that
probably
would be a good project for a student project.
Yes, we will think on that. Yes, Dr. Hall, I think we are done with the questions. So once more, thank you so much. Thank you so much for accepting.
Thank you, Fabio. It's been a pleasure. And again, I invite all of you who are listening, if you have a chance to visit with us after COVID. But Fabio, we certainly hope you'll come back and see us again. We really appreciate all the work you've done over the years. You're still collaborating with us, which we appreciate. So thank you.
Thank you so much. It's a very good pleasure. Thank you, Dr. Hall. See you. Bye-bye. Agora eu posso finalizar. Vamos